Today's lecture is a brief overview of public health, and I will post some additional readings. This is new in this course, and if you are a public health student, an MPH student, you may have seen some of this material before. We are required to include it for accreditation in this class as well as in the Introduction to Public Health. But you know what? It's good to get an overview to refresh your memory, and if you haven't taken the Introduction to Public Health yet, then you will have a little bit of a leg up. And these are the learning objectives for this lecture. One is to describe the scope of public health. What are some definitions? Then outline a history of public health with particular focus on the United States. And this is kind of a broad brush discussion. I will not expect you to know specific dates or anything like that. You do need to be familiar with the 10 great public health achievements of the last centuries and the top 10 causes of death back in 1900 as well as today. What has changed and what ones are still on there from that were there in 1900, which ones have increased and which ones have decreased. Define, and then finally to define and give example of the 3 functions of public health. And under that, I would also add the 10 essential public health services, which I'm not going to address in this lecture, but I will post a handout so that you can refer to those with the materials for this week. So, just what is public health? If you ask the average person in the street what they think of when they hear the words public health, you're likely to hear answers ranging from the people who do immunizations, to the people who inspect restaurants, to healthcare for poor people, and a variety of other activities carried out by government agencies. Most would have some concept of public health as a collection of the activities of government agencies like the CDC, the FDA, the NIH, state and local health departments, the dog catcher, so on and so forth. Some see public health in terms of the workforce. Public health nurses, nutritionists, environmental health specialists, nurses, doctors, sanitarians, researchers, lawyers, and others. This perception may result in part from the way that many state health departments were organized during the last half of the 20th century by specialty or by profession within public health. In the academic and healthcare world, public health can be seen as the knowledge base and techniques that make up the toolkits of those professionals and government agencies. For example, epidemiology, biostats, health education techniques, and library science. Bernard Turnock's perspective in all of his writing is that public health is really a broad social enterprise, a system with the definite social justice mission to provide health care and living conditions to all citizens of a country. This perspective calls for a population-based approach to solving health problems. A small portion of people might perceive that the term public health actually refers to the health of the public or the health of a whole population. From the Institute of Medicine's 1988 definition, I'll quote, "Public health is fulfilling society's interest in assuring conditions in which people can be healthy." This is one of the ones that you will see quoted most often today, along with the World Health Organization definition. It sounds very simple, but in order to accomplish it, the health system as we now know it will need to be turned on its head. Before I end this slide, I want to make a comment about something in your textbook on page 6, where the author talks about public health versus medical care. And I noticed this in other textbooks too, and I actually got a comment on this a few years back in my course evaluations about the dichotomy, or it seems that the author or some of the lectures were pitting public health against the practice of medicine. And I totally disagree with that perspective. I think that they complement each other, and I think that without public health, you might not have the practice of medicine. if you think back to the early origins of the discipline of medicine, particularly in this country, they were launched around issues like epidemics and so on and so forth, and that's how the practice of medicine began. But also public health is integrally related to the practice of medicine. So when you see headings like public health versus medicine or versus the practice of medicine, kind of take that with a grain of salt, because they both go together. I would rephrase it as public health compared and contrasted with private medical care. Ideally, at some point, they will be merged and it'll just be a continuum of services. And some of this is actually about professional turf. And I think that in public health, we have felt like the underdogs for a while. And so we feel it necessary to proclaim our discipline as equal to that of medical care, and I've never had any doubt that it was. So that's kind of the perspective that I urge, and that's enough of my soapbox for this lecture. Next slide. And here is the World Health Organization's definition of health: a complete state of physical, mental, and social well-being, and not merely the absence of disease or infirmity. Next slide. This figure comes from a presentation by the late Fay W. Bozeman, the former director of the Arkansas Department of Health, who used to give a guest lecture in this class. Dr. Bozeman was fond of showing this slide to illustrate what our vision and mission are for public health, in line with the Institute of Medicine definition. A societal focus on wellness at the community level forms the base, with what are traditionally thought of as public health services next. The size of each layer in the triangle represents the priority and the need for funding and other resources for that particular area. In a society that fulfills the conditions where people can be healthy, there would be a far smaller need for remedial or tertiary medical treatment, the high-tech sort of medical treatment that you see in large medical centers such as UAMS. Contrast this with the next slide illustrating the system that we currently have. This inverted triangle of the healthcare system that we have illustrates the current focus of our healthcare system. The topmost area, remedial treatment, includes secondary and tertiary care. This is where most of the resources, financial and otherwise, are expended today. Dr. Bozeman liked to use the story of a community infested by snakes or alligators from upstream. It's easier to go upstream and catch the culprits before they hatch. Because we're not catching the culprits, the risk factors like smoking, poor diet, lack of exercise, before they can do us harm, the remedial treatment creates quite a burden on society in terms of finances and also in terms of hours of care and time spent caring for sick relatives and others. So how did we get where we are today in public health, and what are some of the milestones that we crossed along the way, and how are we going to attempt to turn the triangle upside down? Next slide. It might be a bit of a stretch to go back 7,000 years, but I'd like to use this slide to illustrate that humans have known or suspected for a long time that contaminated water can cause disease. This is a picture from the Bettman Archive of Ancient Babylon. The Babylonians had an elaborate system of aqueducts, clay sewage pipes, and a sophisticated pumping system to bring in fresh water every day. Of course, as history progressed and wars intervened, this system and the knowledge that created it fell by the wayside. And I think that we've seen that several times in human history, that we've begun to get a grip on public health and how to take care of the public's health, and then events of history intervene and the knowledge is lost and we have to start all over again. Next slide. This is Hippocrates, a Greek physician born in 460 BC. The Hippocratic Oath is still alive and well today in our medical profession. Most people probably don't know that Hippocrates was not only the founder of medicine, but was also a very advanced thinker for his time. He believed that illness had a rational physical explanation and was not caused by possession by evil spirits or the disfavor of the gods. He believed in the natural healing process of rest, a good diet, fresh air, and cleanliness. He also noted that there were individual differences in the severity of disease systems, and that some individuals were better able to cope with their disease and illness than others. He is attributed with the quote you see here. Skip to the next slide for an English translation. And here, the English translation, cleansing doth prevent infection. What's interesting to me is that this was 2,400 years ago, and yet hand washing is still a major concern when looking at measures of infection control in hospitals today. So even though we've known this for many years, it's still something that we have to teach people at the most fundamental level, even professionals who are involved in patient care. Next slide. Now we come to 2,000 years ago with the Romans. They were in some ways very concerned with public health. It was kind of a dichotomous approach that they took. They understood something of the link between cleanliness and good health, since they did build myriad latrines, drains, sewers, and public baths. And yet, from the shops and the upper windows of their apartment houses, people recklessly tossed rubbish and other waste into the middle of the street with little concern for consequences. They did make great progress in the area of sanitation by building aqueducts to bring in fresh water and building sewer systems and public baths. However, with the fall of the Roman Empire, much of the knowledge that they developed was lost and was not passed on. Next slide. Some of you may recognize this famous picture of a physician from the Dark Ages, from the fall of the Roman Empire in 476 until about 1000 AD. The physician is draped from head to toe in robes, equipped with a mask and a long beak, and a stick for poking patients to examine them without touching. The beak contained herbs to protect him from the vapors coming from the sick and dying, not because the germ theory of disease had been discovered, but because the smell was bad and associated with those pesky evil spirits that were still considered the cause of disease. European towns were dirty and crowded, and disease and epidemics spread unchecked because of the lack of sanitation. Water was contaminated and personal hygiene was virtually unknown, and also people were beginning more and more to gather in cities, and so you have a perfect setting for the spread of an epidemic or an outbreak. TB, cholera, diphtheria, smallpox, yellow fever, all of these were rampant. As many children died as lived, and the average lifespan was under 30 years. Of course, the one cause of death that we have all heard the most about from this time period was the bubonic plague, which is outlined in a little more detail on the next slide. 3 major pandemics of bubonic plague have been recorded. Now, I put quotes here around the word pandemics because technically a pandemic is an epidemic that impacts on the whole world. However, the world was not connected in the way that it is today during those time periods. So these were pandemics for the part of the known world or for certain parts of the known world at that time. In the Middle Eastern and Mediterranean countries, 50% and 40% respectively of the population was killed during the first time period. 60 million people died between 1338 and 1341 in Europe alone. That's an amazing number. The plague had spread to every major continent by 1855, so in that sense it actually was a pandemic. In London in 1665, only the Great Fire of London killed all the rats and fleas, putting a halt to the plague. So you have one disaster putting a halt to the other. When I was in London a few years ago, they had opened a museum dedicated to portraying the bubonic plague and the Great Fire of London. It was truly horrifying. I should also add here that the last urban epidemic of plague in the United States occurred as late as 1925 in Los Angeles, within the memory of some people living today. Of course, we now know that the plague is treatable with antibiotics, but this was less than 100 years ago that it was still a major public health concern. Okay, the United States in the 1700s. In the early days of this country, the main public health focus was on keeping disease out of cities. There were two schools of thought on the causes of disease, infectious disease. Some thought that foreigners brought disease with them into our port cities, and they advocated for quarantine and isolation. In fact, the word quarantine comes from the Italian word for 40, which was the number of days that ships were to be held offshore if sailors were infected. The indigent sick were held in infirmaries of the almshouses. Others who had been turned out by their families resided in pest houses, the origins of our modern-day hospitals. Another group of people, the early progressives, pointed to the filth in the streets of our own country, the sewer systems or the garbage collection services that were primitive in locations where they even existed. Dead animals were left to rot in the street along with the garbage. Early advocates of sanitation practices believed that there was something in the air or water associated with dead animals and garbage that carried human disease, but the germ theory of disease was not developed until the late 1880s. There was a quote in a textbook that I used earlier, and I can't remember which one it was, that the author thought that probably the automobile was one of the biggest contributors to the health of the American people because it ended up removing all of the dead animals, all of the dead horses from the streets. I think that may be a bit of an exaggeration, but if you can picture using horse and buggy for travel and having not good sanitation still and not good plumbing, you can imagine what it was like in the early days in this country. Next slide. Great sanitary awakening of the 1800s. At the beginning of the 19th century in New York City, living conditions were nearly as filthy as in the Middle Ages, and yearly epidemics swept through the populations, killing many. The average lifespan was less than 40. Although the smallpox vaccine had been developed, it was not universally accepted. But during the mid-1800s, the physical link between germs and disease began to be uncovered. Soaps, disinfectants, and pharmaceuticals began to be developed, and it was recognized that disease could be controlled through cleanliness some 20-something hundred years later. This began the sanitation revolution, and public health practices such as garbage collection, water treatment, public health departments and regulations, as well as personal bathing became part of the culture. Two national epidemics, the yellow fever epidemic of 1878 that raged along the Mississippi River, and the Asiatic cholera epidemic of 1892 that hit New York City with particular ferocity, were the impetus for the National Quarantine Act of 1878 that was strengthened in 1888 and again in 1893. This gave the Marine Health Service the legal authority to issue orders of quarantine. The last 10 years of the century, of the 19th century, were important years for public health. They're often described as the birth of bacteriology, a time when many of the microbes causing various diseases were identified. One scientist of the era remarked that in 1890 we knew nothing. Now, anything is possible, and I think that now was 1900. The death rate in children dropped, and the average lifespan increased over the years to age 47 by 1900. But on the next slide, let's back up a few years to the mid-1850s, even before the germ theory of disease was accepted medical knowledge. In the mid-1850s, as previously noted, there were two major theories and many minor ones, such as the supernatural and miasma, etc., about the transmission of cholera. Dr. Snow used techniques which would later be known as medical geography and epidemiology to confirm that the transmission of disease occurred by swallowing contaminated water or food and not by inhaling infected air, at least not always. Dr. Snow knew that he had identified the transmission method for the cholera poison. This poison was later identified as the bacterium Vibrio cholerae. Cholera leads to an infection of the small intestine, which results in extreme diarrhea and sometimes massive dehydration and death. The disease can be treated by giving the victim a lot of fluids, either by mouth or IV. The organism was not discovered until 25 years later by Robert Koch. In addition to discovering the causative organism for cholera, Koch also discovered the causative organisms for tuberculosis and anthrax. So again, that's part of the bacteriological revolution. One thing about this map, John Snow mapped all of the cases of cholera and tied them to one particular pump in an area of London where workers would go to pump their water. And he found that workers in another area very nearby were not infected at all. And it turns out that's because they were working in a brewery and they were given beer to drink on their break. So that's just kind of a little known fact about John Snow. And many of the techniques that John Snow used and developed are used even today. If you will look in your textbook in the prologue, the short little section on Cryptosporidium and Milwaukee water, you'll see that the outbreak investigation that they did was very similar to what John Snow did, although they had much more high-tech means of doing it. Next slide. The 1800s in Chicago. This slide contains a table from Bernard Turnock's first book that I think illustrates the progress made in the 19th century in public health very well. There's a story in that book about the Chicago River in 1900 that's truly amazing. Prior to 1900, the Chicago River ran into Lake Michigan. This meant that the garbage dumped into the river would flow into Lake Michigan, where polluted water carried typhoid and cholera right back into the city. In 1897, engineers began digging a channel from the Chicago River down to the Mississippi River drainage system. The water could now flow directly from Lake Michigan through the city, greatly reducing the risk of infection and sending it downstream, hopefully not to St. Louis. Next slide. Okay, here we have the top 10 causes of death in 1900. As I noted before, life expectancy at birth was 47 years in 1900. The top 3 causes of death were infectious diseases, and perinatal conditions included infections, and that's conditions around the time of birth. I should point out here that 47 was the average life expectancy. This doesn't mean that most people only lived to 47, but rather that there were so many deaths at early ages, particularly infants and children, that the average age was brought down significantly. Next slide. We've really made the transition from infectious to chronic diseases as the major causes of death in this country. I think we tend to take this transition for granted. As many public health leaders have noted, the public tends not to notice public health as a profession until something goes wrong. The next set of slides contains charts and graphs illustrating some significant contributions that public health made during the 20th century. It will be important for you to be familiar with all of these, both as a public health student and as a public health professional who may be called upon to describe just what it is that public health does. Next slide. Vaccination and infectious diseases. This graph represents deaths per 100,000 population for all infectious diseases in the United States during the course of the last century. Please note that you will be seeing death rates expressed as deaths per 100,000 population throughout this course, although there are some exceptions. Infant mortality is deaths per 1,000. But generally speaking, mortality rates for the country as a whole are expressed as deaths per 100,000. In 1900, a full third of all deaths were caused by the top 3 infectious diseases, and 40% of those were to children under 5. But we didn't have any of the vaccines to prevent these diseases until well into the 20th century. Even the smallpox vaccine, which was developed around 1800, was not widely used in 1900. Penicillin was used on a large scale first in 1940. So what accounts for the precipitous drop in infectious disease deaths early in the century? Activities such as sewage disposal, water treatment, chlorination of water, proper food handling and hand washing techniques, and other hygienic practices all contributed. You might notice the spike in death rates, the huge spike due to the influenza just before 1920. This was the great influenza pandemic of 1918. If you're interested in reading about the historical development of public health infrastructure, policy, and politics in a well-written book, I highly recommend The Great Influenza by John Barry. It reads like a historical novel and gives some insight into what the CDC and other agencies would be up against today in the event of a pandemic of flu. One of the things that I might ask about in the discussion for this week is what you think might be responsible for the upturn in that curve from about 1980 on. And granted, this only stops at 2000. I would love to get a more updated version. But anyway, what do you think accounts for the uptick in that curve between around 1980 and 2000? Next slide. Next, motor vehicle safety. This graph illustrates the number of deaths per million vehicle miles traveled, the dark line, compared with billions of vehicle miles traveled overall. It makes the striking point that although we were driving about 6 times more miles in this country in 1995 than we were 70 years earlier, the numbers of deaths per mile traveled decreased by 90%. The decrease is due to several factors. Changes in highway regulation and design instituted in the 1960s, along with requirements for safety features in automobiles, highway barriers, rails, and breakaway barriers, and tougher, more thoroughly enforced drunk driving laws were all part of the interventions. You may not typically think of these as public health issues, but they go to the heart of the Institute of Medicine definition of public health, fulfilling society's interest in assuring conditions in which people can be healthy. Next slide. Safer workplaces. The data for this chart only cover the years 1980 through the late 1990s. Reliable data on causes of death were not available before that time. However, we do have estimates that deaths due to industrial occupations were approximately 61 per 100,000 in 1913 and 37 per 100,000 in 1933. The data here are for separate causes of work-related deaths. The 1970s were a time of greater awareness of the physical and chemical dangers of workplaces, and the Occupational Safety and Health Administration, OSHA, the Mine Safety and Health Administration, and the CDC's National Institute on Occupational Safety and Health were all created during that time. The Federal Mine Safety Act of 1970 and changes to electrical code standards and increased oversight and regulations are credited with a dramatic reduction in the deaths of miners and deaths due to electrocutions. Again, we may not think of workplace safety as a public health function, but occupational health and safety is one of the main focus areas, or was one of the main focus areas, of the Healthy People 2010 initiative. This is an area where the public health function of policy development continues to be an important force. The National Council on Occupational Safety and Health is a nonprofit umbrella organization of networks that provide advocacy tools, such as the Dirty Dozen annual list of the 12 companies with the worst record for health and safety. I have included their web address in this slide for those of you who might be interested. Next slide. Deaths from cardiovascular disease. Although cardiovascular disease is the leading cause of death in the United States today, the rate per 100,000 has decreased dramatically since its peak in the mid-20th century, as you can see in this graph. By the way, these are age-adjusted rates as contrasted with the crude death rates presented in the infectious disease slide. Age adjustment allows us to take into account the number of elderly people in a population. This in turn allows us to compare deaths in 1920, when there was a much smaller proportion of elderly people in the population, to deaths in 1998, when there was a much larger proportion of the elderly. It also allows us to compare across populations, which we will also come back to later in the course. The decrease since that time can be attributed to both medical care interventions such as open heart surgery and public health interventions, including the campaign to eliminate cigarette smoking. Notice much less pronounced change in age-adjusted death rates from stroke over the same time period. Think about what could be the reason for the difference in this rate of decrease between stroke and coronary heart disease, or all diseases of the heart. This would also make for a good discussion question this coming week. Next slide. Next slide. Healthier babies and mothers. This slide illustrates the steep decline in the infant mortality rate in the U.S. from 1915 to 1995. While overall mortality is usually expressed as deaths per 100,000, as I mentioned earlier, infant mortality is expressed as deaths in the first year of life per 1,000 live births. This is because the population of births each year is a small proportion of the overall population. In 1915, 1 out of every 10 babies born in the U.S. died within the first year of life. The current infant mortality rate is around 5 deaths per 1,000 live births. This improvement resulted from many of the same public health interventions during the early 20th century that brought reductions in waterborne and foodborne diseases. It was only during the last 20 to 30 years that improvements in tertiary care for premature and low birth weight babies were introduced. So the majority of the reduction in deaths came about through public health efforts. While our infant mortality rates are much improved, we still rank as one of the worst industrialized countries on infant mortality, as well as a host of other indicators of population health. And there are disparities by race, geography, and socioeconomic status, to name a few. The black infant mortality rate has remained consistently almost twice that of white Americans. In fact, in many U.S. counties and inner cities, infant mortality rates are higher than those of developing countries. We will see many examples of this phenomenon throughout the semester. A question raised often in the public health professions and in public debate is why the richest country in the world, with the best healthcare system in the world, falls behind so many other countries on these basic measures of human health status. Next slide. And this chart comes from HRSA, HRSA, the Health Research and Services Administration, the principal federal agency charged with increasing access to health care for those who are medically underserved. HRSA's goals are remarkably similar to the goals and objectives of the Healthy People 2010 initiative. This graph illustrates what I talked about on the slide before, that in spite of having the largest percent of our gross domestic product of any country devoted to health care, the U.S. still falls way below many other countries in terms of infant mortality, a primary indicator of the overall health of a population. Next slide. Fluoridation of drinking water. The dotted line represents the percentage of communities with fluoridated drinking water. The solid line represents the mean number of decayed, missing, or filled teeth in age 12 school children. This is a very rough abstraction of two trends, partially because of the lack of data in this area. The actual crossover point in the early 1980s doesn't represent an event or a significant time in oral health history. What the trends imply is that as we have fluoridated more and more of our water supply, we have experienced improved oral health care in our children, or oral health in our children. Next slide. The final slide in this series has an excellent set of historical milestones attached. The indicator tracked on the vertical axis is the annual adult per capita cigarette consumption in the United States. The first thing that struck me when I saw it was the drop in cigarettes smoked during the Great Depression when money was scarce. This drop would later lead public health and other government officials to use taxes as a disincentive for smoking. The most striking implication of this graph is the obvious impact of the Surgeon General's report, the ban on advertising, and the non-smokers' rights movement in turning the tide. Recent efforts to also turn the tide of obesity in this country have modeled themselves after some of the tactics used in the fight against tobacco. Although I'm not sure that I agree with the proposal to take toys out of Happy Meals. That was a joke, by the way. Next slide. Age-adjusted death rates per 100,000, and this is for the top 10 leading causes of death in the United States for the most recent 5-year averages that are available. Note they're age-adjusted. If they weren't, then the rate for deaths due to Alzheimer's for those 85 and older would be 818.8 per 100,000. But what a change from 1900. While pneumonia and influenza are still in the top 10, 6 of the top 10 are now chronic diseases. And alarmingly, suicide and Alzheimer's disease are the only ones that have gone up. The rates have gone up since 2011. I have some data from 2011. And of all of these diseases, the rates of everything else has gone down, but the rates for suicide and Alzheimer's have increased. I'm going to conclude this lecture with the 3 functions of public health designated by the Institute of Medicine in 1988. They form the core of the 10 essential public health practices which are public health services which are posted in your materials for this week and which you really need to print out and look over. Assessment includes activities such as surveillance, understanding the etiology or determinants of disease, and trends and outcome research. Policy development involves making informed decisions about health problems, goal setting, analyzing approaches, allocating resources, and evaluation. It needs professional expertise. The Institute of Medicine, CDC, the National Center for Health Statistics, HRSA, and National Institute of Health are some of the federal bodies performing this function, but policy development takes place at the state and local level too. It was a combination of federal and state policymaking that resulted in Arkansas using the tobacco settlement money to create the College of Public Health. Assurance. This involves legislative mandates for spending and regulation, statutory responsibilities, providing direct services, health inspection, and public health law. This is generally done at the state and local level, although the federal government has broad powers over areas such as food safety, bioterrorism, emergency preparedness, and epidemic and pandemic situations. In conclusion, I put a series of bullets on this slide that will be helpful to you in preparing for questions for the final exam. There are going to be a couple of questions about public health in the final exam. I'll let you know ahead of time. There were also some other questions in the lecture for you to think about that might pop up on the exam in one form or another. By the way, it's easier for me if you email me through the Blackboard email in the course, which is on the left-hand column, because I get so many emails at my UAMS webmail that I often miss those that are specific to a class. I'm not going to be in town next week, but I will post the lecture as usual, and next week we'll be talking about the Affordable Care Act today.